I'm Rick John. I'm a study coordinator for the PRISM studies based in Tororo. And I'm going to talk to you about persistent malaria transmission from asymptomatic children despite highly effective malaria control in Eastern Uganda. By way of introduction, we know that in addition to other interventions, vector control and case management are really central to malaria elimination efforts. And yet, in the clinics, for us who sit in the clinics, symptomatic cases we see during this case management reflect only a tiny fraction of Plasmodium infections. The majority of infected individuals are asymptomatic. Unfortunately, we have a poor understanding of the relative contribution of symptomatic and asymptomatic infections to onward malaria transmission, especially in low endemic settings. It's however known that infection density, gametocyte production, and treatment for malaria affect malaria transmission. So in this study, we really sought to understand the contribution of symptomatic and asymptomatic infections to the infectious reservoir. Secondly, to longitudinally quantify the contribution of different populations to the infectious reservoir, and also to understand the relationship between parasite density, gametocyte coverage, and effectivity to mosquitoes. We did this study in two settings, one where there was really effective control with IRS, a long endemic area in Tororo, almost in the center of Tororo, a place called Nagongera, and also at the border between Tororo and Busia, what we now call the border cohort study. So to be able to answer these questions, we leveraged on our well-characterized cohorts of households and its members from our PRISM studies in this area. The study participants came to our clinics for all their medical care and for study appointments. Now, participants to be selected for membrane feeds were either symptomatic on the day of clinic visit or had an asymptomatic infection detected by qPCR 1 month earlier. And for these participants, we took 3 ml of blood and fed it to 60 to 80 mosquitoes through a glass membrane feeder for 10 minutes. And fully fed mosquitoes were kept in our insect tray and dissected at day 10 for oocyst detection by microscopy. Now, the picture on the top right there is our insect tray in Nagongera. This is where we do colony maintenance and feeds. The middle one is a mosquito feeding the glass feeder, and then below is a picture of an oocyst that we picked through the microscope. So here we were able to do 538 experiments, or slightly more, and these first plots really talk to the contribution of gametocyte density to transmission. The solid circles represent gametocyte density from asymptomatic infections. And the hollow ones represent gametocyte density from asymptomatic infections. The red color there are children under 5, the green are 5 to 15-year-olds, the school-going children, and the blue what we call adults, those above 16 years of age. And what we see here, the y-axis are the infected mosquitoes, and then the x-axis is gametocyte density per microliter. And what we see here is that adults have the lowest gametocyte densities and are also less infectious. These are the blue colors you see there. And also gametocyte density was strongly predictive of mosquito infections. As you can see, the higher the gametocyte density, the more mosquitoes are infected. And indeed, mosquito infections rapidly increased above 10 gametocytes per microliter. Also see that symptomatic cases, though they had gametocyte densities were very low and less infectious. These are the hollow circles. So we see less of them as the curve goes up. And importantly is that asymptomatic, participants, as you can see, the solid circles there in both graphs, especially children 5 to 15 and those under 5 contributed the most to infections. Now, these two graphs really, the one on the left is the low endemic area, and then the one on the right is the border area. So we did studies in these two areas with participants from those two areas. We got interested also in estimating the contribution of different populations and age groups to the infectious reservoir. And this, the upper plot is participants from the low transmission area. And then we're not able to show the plots for those from the high transmission area. But what we see is that for the upper plot, plot A, the width of the graphs represent the proportion of infections from the different subpopulations. This one is really talking about the contribution of the different infection types to the infectious reservoir. The coffee brown representing the symptomatic infections. The orange there are asymptomatic microscopy detected infections, and then the yellow are asymptomatic infections. The heights of the graphs are the proportion of mosquitoes infected, and the percentages there are the estimated contribution of the infection type to the infectious reservoir. What we see is that the asymptomatic microscopy detected infections contributed 83.8%, the most to the infection reservoir. And then the plot below B is really talking about the contribution of the different age groups to the infectious reservoir. Again, the width is the contribution of those different ages to the different subpopulations to the infection. And then the height of the plots there are the proportion of mosquitoes infected, and the percentages are the contribution of the different populations to the infectious reservoir. And what we see is that children 5 to 15, these are the school-going age children, contributed 56.8, the most to the infectious reservoir, followed by children under 5. Now, on the left, we're really comparing what we saw in the low transmission area and the high transmission area. What we see that in the high transmission area, the contribution of the symptomatic infections increased from 0.6 to 5.3%. And also the contribution of children under 5 increased in the high transmission area, which was the border between Truro and Busia, from 27 to 36.7%. That's a significant thing we see there. We're also interested in following up infection dynamics of participants to longitudinally quantify infectivity. Here, we're really showing 4 of the most infectious individuals that contributed more than 50% of infected mosquitoes. So these are participants we followed from January 2018 to 2020, January. The crosses here, each of those colors you see infections, and the crosses or the X's there are symptomatic infections. The solid squares asymptomatic microscopy positive infections, and the hollow squares qPCR or asymptomatic qPCR detected infections. The red are infectious individuals, so every red color you see is an infectious feed. The blue are non-infectious feeds, and then the gray are the time points when we didn't do any membrane feed on the participant. So multiple feeding assays were done on each of these individuals, as can be seen. And they were infectious at multiple occasions, as shown by the red, and then non-infectious on other moments, which are shown by the blue there. I could give an example of ID number 13, the one on top. This individual harbored infections from January 2018 to almost to January 2020, and through that period didn't have any symptomatic infection. So there's no single X coming up in all that period, but had several infectious feeds with both microscopic and submicroscopic infections, shown by the red and the red squares, and at different points had also asymptomatic infections that were infectious. The hollow squares. ID3, for example, had a very short infection, and three of the 5 feeds done when they are asymptomatic, microscope positive, were infectious. These are the red solid squares seen there. So what we see here, what we conclude is that both short and long infections contribute to contribute to transmission, and many infections in this area didn't seem to become symptomatic. So in summary, in our setting, Asymptomatic microscopically detected infections, especially in school children, seem to be the most important drivers of transmission. Clinical cases were less important for transmission, and we were able to identify a subset of super spreaders that harbored asymptomatic infections for a very long time. And these infections were of different parasite densities. And we think identifying these populations that sustain malaria transmission will be key for elimination of the infectious reservoir, but also control of malaria reappearance after effective malaria control. For policy, we think targeting reservoirs of malaria control of malaria infection with effective chemotherapies can be an option for malaria control. And school children provide, we think is an opportunity, an important opportunity since they're accessible. And so targeting them by malaria control interventions such as chemotherapy may be an important, strategy that could be explored. So I want to thank you all for listening and acknowledge all those that are, featuring on this slide. Thank you.